So the emergency lecture series topic today is supposed to be status epilepticus and treatment, and I guess you're guys are going down to learn the basics of EEG hookups in about 10 minutes. So we can go through some basic topics here. Status epilepticus is defined as continuous seizure. There's a couple definitions. One is continuous seizure for 30 minutes or longer, or alternatively, you can use a more working definition of about 5 minutes, because once you get to 5 minutes, you keep going. That's really the reason for that. Discontinuous events that last, say, a matter of a few minutes and are compounded within 30 minutes count as sort of the same situation. It's basically seizures that aren't fully controlled. Mechanism is basically that the brakes which control the brain fail. And so you think about the wiring of the brain, it's about 85 to 80 to 85% GABAergic and inhibitory, and that's what's failing. It's the majority of the brain. So situations where this often happens is hypoxia, where you're losing a substantial portion of the brain, or if there's some kind of irritant that is interfering with nerve function. Think metabolic encephalopathy, overwhelming meningitis, things like that. Typical seizures last about 1 minute, and this is why you start to scramble around 5 minutes. That's lost in space, I think. Classification of status is based upon the type of electrical activity. It can be generalized status, it can be focal status. Focal status is a bit different creature in that it can be more persistent, it can be harder to get under good control. It can burn out a part of the brain. If something is twitching with the status, it will continue to twitch until it stops moving, and then usually doesn't move as well afterwards. That's EPC, or epilepsia partialis continua. It can be challenged because clinically we can treat it. We can get somebody to go into full coma, and yes, it'll stop. But then when we wake them up, what happens? So it's a little bit of a debate. It depends on how bad it is. Subclinical seizures can also be in status, in that you can have electrical activity raging in the brain without any overt manifestation, except altered level of consciousness or coma. And sometimes brainstem activity is just fine, so patients can actually breathe and the heart will be fine, and it can still be in subclinical status. Absence status is a rare phenomenon, but you can have persistent generalized spike and wave activity. Typically, you have a staring spell, and it can be persistent. And then psychogenic status. Psychogenic status would be pseudo-seizures that persist. Really hard to treat with seizure medicines. So generally, we treat with anxiolytics, and generally that will help more than the seizure medicines. Differentiating is difficult, almost impossible without an EEG. So more mechanism. So again, it's the same principle as I mentioned at the beginning. Glutamate is excitatory, GABA is inhibitory. Usually inhibitors win and control things. The brain's actually wired to keep things in check. This helps also focusing your attention, because otherwise you'd be thinking 2 million thoughts at once, and nobody can really do that. Balance changes in status epilepticus and the excitatory stimulants are more prevalent. I think part of this is thought to be due to glutamate toxicity, but it's a little ambiguous. Enate, which is an analog, certainly contributes to it. And if you have persistent status, you get hypoxic state, which means diminished blood flow, neural death, and the whole thing gets worse in that it becomes truly refractory. Prognosis is pretty poor. Epidemiology, about 10% of the population have a seizure, and that's across the board. 2% have epilepsy, which means 2 or more unprovoked events. And then of epileptics, about 4 to 16% have status at least once. So those are the numbers. The numbers per patient years varies widely. 40 is a peak that the group in Virginia hit a few years, about a while ago, about 25 years ago or so. And 7.5 is probably a little bit on the low side. I would put it more around 20%. And
is that related to access?
It relates to, I think there's some demographic thing going on, because you'll see more here than you will by far in Montgomery per patient years. Our patient population is about a quarter of here, but we don't see anywhere near the number of status cases. So, and the population that they have the high numbers in is actually kind of a rural Virginia population. Nathan, cases of status in adults. This was a study in San Francisco in 1993. Causes, as you see way up there, is withdrawal of seizure medicines, and that's a pretty powerful stimulant. Alcohol withdrawal is the second. Drugs intoxication itself, rather than withdrawal, and then CNS infection, and we go through some other causes. Tumor, if it presents with status, is usually more focal status, but it can be generalized as well. And metabolic tends to be generalized. Stroke, probably more focal. Cardiac arrest, or generalized. It sort of depends on what the cause is doing to the brain at the time. Participant precipitants in children is quite a bit different. These are not typically long-term epileptics. The main cause is fever. Medication change, which is kind of related to medication withdrawal, is number 2. And then there's a bunch of smaller contributors. Tumors, by the way, this is part of another talk, but in children, yes, there's a lot of pediatric tumors. There is a spike in tumors in kids, but it's a relatively small portion of patients, and most children with epilepsy have more idiopathic or non-lesional epilepsy. Stages of status epilepticus. First, you start out with discrete seizures, presumably, and then you have waxing and waning ictal activity. It can build up to a level where you get continuous activity, and then if it persists, then you start getting persistent activity or full-out status, with breaks in between, which is flattening, and then you can develop into PLEDS. PLEDS is periodiform discharges, so usually lateralizing, but not always. It can be bilateral. And notably, last little point here, not all steps are needed in this cascade. It should be going downwards. You can start right to the bottom if you want. It depends on what the stimulus is to the brain. So oftentimes, hypoxic injury will go straight into PLEDS. This is an example of persistent activity with little tiny breaks. There's a half-second break there, and there. And then the rest of it is rhythmic, sharp and slow activity, persistent seizures. This is more intermittent activity. I think second is the bottom bar right there. And you're seeing more PLED-like activity here, where this is actually lateralizing to the left side more than the right, although it's present bilateral. And this is actually independent of that. So we got 2 foci, 2 sides firing independently with lateralizing activity. Outcomes. Mortality is somewhat variable. These are very different numbers, 4% to 37%. So I think it depends on the cause, whether you can reverse the cause. If you can't reverse the cause, I think 37%. If you can, then you're probably going to be a much lower number of mortality. And timing is kind of important. The data on status that lasts more than 24 hours is pretty poor, in that most of those patients are going to be not surviving. We're talking about 85%. So the first 24 hours is kind of a crucial time frame. Hauser did a big study. I think they're also on the West Coast in 1993. 63% survived, then 28.6% died from underlying cause of the status. 6.6% died of other causes, and 1%, only 2% actually died of status itself. So pointing back towards the underlying causes being the problem. Treatability plays a big role, and duration. Again, more than 24 hours, you're looking lower viability. Immediate management, ABCs, vitals, start IVs, and thiamine and D50, then meds. And we have a protocol. I just reached out to Dr. Dejesus, who was putting that together. She's going to be getting to us very, very soon, she said. So we have a rough version, but as soon as I get the finalized version, we'll be distributing that. Prior history is kind of essential because it'll differentiate between somebody who's missing medicines or might have metabolic encephalopathy or an overdose. You need that kind of information in order to appropriately treat. Prior meds, for seizure patients are kind of crucial. If they've been controlled with something in the past, that's exactly what you want to give them. If you can, get imaging because there can be causes that are visible, such as stroke, tumor, or edema.
Is that Treiman D50, is that for every patient or case by case?
If you don't know,
Okay.
if you have a blank, this patient seizing, then yes, I'll get it.
Okay, even though no blood sugar problem, no drinking history?
Yeah, okay. Because it's at such low risk that you should do it in case of, number needed to treat is probably 100 or so, but where you can get some benefit out of it. But it's because the risk of the medicines is so low, yeah, I think I would. If you know something about them, you know they already have seizures, well, then that would change.
And you would do the IV treatment?
I think I would. Yeah. All right. These should perhaps be updated a little bit according to the protocol, but these are the first line medications used in a lot of places. Midazolam could be up there as well. We'll get it maybe in the ER sometimes, but benzos are first line, and that's the reason for that is because they synergize with the GABA system to put the brakes on the seizures. It generally works, but it doesn't always work, and that's where we start getting into the second choices, phosphenotoin and phenytoin. Ideally, the phenytoin is preferred, and I think we've tried to eliminate phenytoin as a loading agent here completely, which is a great thing. There's been times in the last 20 years where that was not possible because phosphenotoin was in short supply. But I think we have enough now to cover at least this hospital. Phenobarbital was also a main choice for a long time. I think it's fallen a little bit out of favor, partly because of cardiovascular effects. But it is a valid choice. If you do load it, you need to think about intubation and the consequences of that. And the patient will not clear the medicine for, well, with just a single load and no maintenance, it would be 2 days. So. All right, effective first line treatment, chance of stopping the seizure. This is from the treatment study of the VA. Razepam is pretty good. And it is the first line. By the way, for most patients, you can use up to 10 milligrams before having to intubate. It's a rule of thumb. If they're starting to get groggy at 6, that changes things. You can generally get away with that. Diazepam and phenytoin is a little bit less effective. Phenobarbital in the range, but also a little less effective. And the phenytoin is a little lower, and that's partly because it does take some time to run in. That's with the phenytoin rather than phosphenotoin. Phosphenotoin can run in a bit faster.
Because phosphenotoin is actually active.
Phosphenotoin is actually just it's solubilized, so you don't have to put in glycol. And that makes it much easier to administer. You don't get the stocking thing or the blue glove. Second line agents, Depicon. That's actually a reasonable agent, and you shouldn't have to worry about liver toxicity. Cases of actual liver failure due to Depicon are very, very infrequent, but it's always a concern when you have a liver condition. To sort of try to steer around it, but Keppra is now used for status. Loading dose between 500 and 1500 or 20 mg per kilogram, which would work out to 2,000 in average weight adult male.
Some places say 40 to 60.
Yeah, we've been giving
The
more.
guidelines
We've been
are
giving more?
60.
We can give up to like 3
At least,
grams.
I think I do 40 most.
Yeah.
But
Okay.
I don't know what are your
Not-
experience.
Pharmacy.
For status, we do 40. For just like breakthrough, we go with 20.
It's very high load. Okay. I'll update this.
No, what do you think?
Yeah.
I think it's not good to use.
Yeah.
She likes to go.
Well, I
40
could
for
see the
status.
point because, well, I mean, maybe not so much, but to anybody else, there's pretty low risk to doing that. You might be a little loopy afterwards. Okay, that's better than being dead. Vimpat. Vimpat is an alternative. It does have some of the same side effects as Keppra, but they're pretty minimal. And the doses you need to load are much lower. It's not typically used as first line or second line. It's more down the road. On that slide. Refractory status. Now, when it's persistent, and we're talking variable timeframes, but over an hour, you got sort of starting to get refractory, and at 24 hours, that's super refractory. That's when the numbers get a lot worse. These numbers are actually not so much worse, partly because I think, again, the status itself is not doing the patient in, it's the cause of the status, and the viability from metabolic causes can be quite a bit better. Phenobarbital or pentobarbital starts getting used around this time, maybe 18, 24 hours. Midazolam, it starts getting used, and then propofol is probably already been loaded by then. And there are other, basically whatever you haven't tried yet is a valid choice.
Well, this list, what's your order?
What's my order?
Yeah.
I'd probably put
Propofol first?
Yeah, propofol and midazolam first, and then put the pentobarb last. But it depends on how angry that EEG is.
Mhm.
If it's looking like it's not going to stop no matter what, then you might as well load with the pentobarb and get it over with. Because otherwise, you're just.
And if it's not controlled by pentobarb, do you think it's like, okay, nothing can save you, so you just.
Pretty much. It's pretty rare not to be able to be controlled by pentobarb. I can't think of it.
But what if you like we win off pentobarb and this is again?
That's
what do you
true.
do?
I don't know.
I read this meta-analysis in the Lancet. It compared pentobarb, midazolam, and propofol, the infusions for super refractory, and they're all three equally good. But propofol, you cannot give for too long because of the risk of propofol infusion or metabolic acidosis. And they sort of thought that midazolam was maybe a little bit better than the other two. I know we tend to use pentobarb the most.
Is that the comparable study or just
Like a
meta-analysis?
meta-analysis of
Yeah,
all
but
the-
I think the
Yeah.
problem is pentobarb much more used in the
Yeah.
older time where the LTM was not available. So they actually
And she has a point. I think it's
Yeah.
me and Newman and other people.
Yeah,
no, I didn't say that.
It's true. Gray hair rules.
we like pentobarb.
Okay. Also available thiopental. I don't think I've seen that one used here. Lidocaine is you can consider for salvage. Some places use it. Cooling. We do a lot of this. In fact, we do it
We have, I haven't
1 or 2, 3, 4 a week. So
how low?
how low?
Mhm.
We discussed this in grand rounds. I'd go about a degree.
35.
36, 35.
35.
Interesting. Okay. I
You
don't think
want
we
to go?
did.
You want to go 3 degrees?
I don't have a preference. I just said we didn't do for those.
I don't think
Did for one.
Oh, okay.
Blocker.
Blocker.
VNS. So in patients that have a VNS, which is a minority of seizure patients, it's a device that hooks up to the vagus nerve and swiping it stimulates the vagus nerve, which resets the limbic system and slows down seizures. And it's probably most effective for temporal lobe seizures, but nevertheless, it does help. Rectal Valium is used actually all the time out in the field, particularly with more developmental and disabled patients that tend to have protracted seizures. I have about 20, 30 of them. Intranasal midazolam can be used. Buccal midazolam can be used. You have to get it in early, sort of like the lorazepam and diazepam. Okay, ongoing evaluation, continuous EEG, labs, and clinical exam. And the clinical exam, if this patient's really in status, is not going to be much of an exam, but it will give you some clues as to whether one hemisphere is driving, and sometimes you can tell, if it's not subclinical status, you can tell that the seizures are ongoing. So that's helpful sometimes. Oh, the protocol. So this was the original protocol from about a year ago, and I'm going to actually pass over this because I think we've revised this considerably.
60.
60? There you go. The Cosmod 400, which is the same one we had in the slides, phosphenotoin 20 load, and then the phenobarb is probably page 2. Phenobarb should be also 20 per kilogram. And that's hard to convince the pharmacy that you need to do that. Sometimes they'll agree to 10 per kilogram. It's really tough to convince them 20 is really needed. But that's help. Ketamine can be used. It's not, we don't use it a lot here. Okay. Now, the pentobarb is 5 to 15 loading, and then 0.5 per kilogram per hour, up to 5. So 10-fold change. And then phenobarb is 8, that's 18, that goes 20. Okay. And other things to consider. Now, these are kind of a little bit more for maybe patients with EPC or something like that. Tegretol or Topamax, you could add them. Tegretol is only oral, so you'd have to go by NG or some other way, or maybe the patient has partial status and can actually swallow. Topamax is a similar story. Ketogenic diet, obviously this is not someone who's intubated in the ICU. You could try Ketocal through NG tube. Plasmapheresis, sometimes it helps if it's autoimmune. And hypothermia, which actually is 32. There you go. Oh, that's different from 36.
Doctor, why do you give Diamox to some patients?
Diamox. Most of the Diamox have been,
Acetazolamide.
yeah.
One of the patients that Diamox has to girl.
Yeah.
She was-
So she's on Diamox. I think she was on Diamox because of catamenial seizures. So it seems to work a bit better for menstrual associated seizures. She had some real periodicity where she would fire away for 3 or 4 days right with her period and then be more seizure free. So it's probably not that effective for status, but that's why some patients run. Okay, outcome. Hopefully electric storm stops. Prognosis worsens considerably 24 hours. I mentioned that. And EPC can persist for weeks, longer. Again, if it's EPC and it is not involving the whole brain, hopefully it's not involving consciousness entirely, and it's, in that sense, it's not life-threatening. But it can have consequences. You can
So,
lose.
Dr. Bobby, we have one of these on the floor, Anna Williams, and
Are you
she
looking at
just,
EEG right now?
well,
Yeah, she's on LTU.
no,
Okay.
we said
Oh, you
there's no
just
need
took it out.
because we can see her twitching and there's nothing to add by continuing the,
Mm-hmm.
we ran out of machines as well. So,
Yeah.
so we leave her like that because it's not life threatening, or do we keep going up on her idea?
No, if you've already gone through as much treatment as you can to the point where the patient was for a while sedated and still going, then probably it's not going to be
I don't think we
controllable.
sedated her. Or we did not, but not to the point that would
She's
not
not
like intubate her or whatever to that point, just sedated her. And then her twitching is not always associated with sharp on the L2. That's what I'm pretty puzzled.
Okay,
I don't know how to explain that.
so she twitches but no sharp. Okay. So she could have some twitchiness or some myoclonus on
Maybe,
subcortical.
but don't go crazy about it. That's the message.
Yeah, well, not to the point where you completely obliterate their quality of life.
And then she has a tumor. Where,
Remember that. Was
yeah.
it glioma or not?
so we don't know because she refused surgery, which is really hard. It looks like something multifocal, but we don't know what it is. Question, whichever medication are you loaded, are you obligated to continue?
No, you can take it away. The consequence, though, you have to be aware of. I mean, if it's actually helping control the seizures, then the removal of the medicine is probably going to help with the seizures. So, but you're not obligated to continue anything if the patient doesn't wish to, or you don't think
Well,
it's
if the
effective.
status stops, then you are not obligated to continue every agent that you loaded.
You want to try and reduce it, especially after this.
So that is if you added like multiple agents.
Yeah.
But if you're only having one agent that you look at and stop.
Yeah.
Is that like you have to continue that agent, or you can add a different agent?
You could try a different agent.
Okay.
Yeah. If you got control of one, that's
And then is it usually better to try multiple agent without maximize the dose, or it's usually good to have one at least maximize single agent first?
Well,
and then add
they
another
act in different.
yeah. So combinations generally work better.
So even lower dose in combination.
Well, you
Let's say a
Get the
Capra
dose
500
to an
BID
effective dose.
plus,
Get for what?
like Capra 500 BID plus a Dilantin 550 QA, something like that.
Well, the Dilantin would be okay, except that's not status dose, but, and then the Keppra, I think I would probably increase also, and then just go with both. And worry about the consequences of the side effects sort of secondary.
Got it.
They're waiting for us
Yeah.
downstairs.
Okay.
Thank
And
you.
we'll see, you're.
Thank you.
Yeah, me and Maria.
So we just stop this.
Yeah, you can just close it.
Okay, now
EEG
you
look. The filter.
learned about the machine.